The next speaker is from Madrid, Spain, but actually quite far away from the Canary Islands, about 2,500 kilometers from here, from Madrid. And that's Dr. Fernando Sipman, and he'll talk to us about clinical use of open lung tool during lung recruitment maneuvers in adult patients.
Thank you very much. Although I came in last night and I couldn't join the interesting activities before the Congress or the symposium, I'm very glad to be here, and I appreciate very much the invitation to join you today.
I'm sure we can get you on the volleyball team. Don't worry, Fernando.
Well, I was not exactly meaning that one, but well, in my talk I will try to give a view of the opportunity we had to make a clinical evaluation of the open lung tool. We focused on two main aspects in this clinical evaluation. First, recruitment and recruitment ventilation strategies are very dynamic processes, and we were eager to see if an online monitoring possibility was able to add or speed up the process of learning more about the recruitment strategies and speed up the process of applying new protocols, identifying new potential problems by recruitment. And the second focus on this evaluation, and for me the most important one, was to see if lung mechanics by itself, apart from oxygenation, could give enough information to help to guide a bedside clinician through the complex process of an open lung ventilation strategy. So then I first would like to start my presentation reminding the audience about the goals of an open lung ventilation strategy. First, and this is a prerequisite, we need to achieve an optimal lung recruitment. We know that we can achieve this goal by applying high pressures for a certain period of time, but this still remains an empirical process. And once we get rid of the atelectatic regions of the lung, the second most important part of the strategy is to find the lowest possible combination of ventilation pressures that achieve these goals, prevent inexpiratory collapse, minimize inspiratory stress forces, and achieve an even distribution of ventilation throughout the lung. If we don't take this into account, just recruiting the lung and trying to make a contest who can gain the maximum oxygenation, what we're doing is applying size, but we're submitting the lung to a very high stress because recruitment pressures can be very high, without the benefit, because this is how our lung is going to be ventilated for hours and hours after a recruitment strategy. So I would like to, in my presentation I probably will repeat this many times, but just take this, remember this important goal of an open lung ventilation strategy. So the problem is, like Professor Henrichs showed us, is that almost all patients on mechanical ventilation in the ICU have this problem. They have different degrees of lung atelectasis occurring in the dependent parts of the lung. So, and we want to get rid of this because we know this is a major mechanism in lung-induced, ventilation-induced lung injury. So if we take a closer look, we can easily see what dramatic forces are involved in the change from a closed state to an open state. And this nice electron microscopy photograph is showing in a rabbit lung how dramatic these changes are and how much damage we can cause to the delicate structure of the alveoli if this is occurring by each ventilatory cycle. So when going from a closed state to an open state, we probably are going through this situation inside a lung. This is a study published in Critical Care Medicine where these authors applied a microscopic camera to the surface of the lung in an experimental model, seeing the dynamics of alveoli actually through the whole respiratory cycle. And so they found that after inducing a lung injury by twin instillation, they had different alveolar behaviors. On one side, there was no change in size or volume from the most extreme positions from the respiratory cycle. That's inexpiration and inspiration, clearly indicating overextension. On the other end, we had areas of the lung where the alveoli virtually disappeared during an expiration with a complete collapse and having a dramatic change in size and volume within each inspiratory cycle. And other number of alveoli that were what we could consider as a normal behavior with a change in size and volume but without the inexpiratory collapse. So the goal again is try to get to the situation where almost every part of the lung is having this behavior. expressed in a different way, we're looking for an optimal window of pressures. This means that our PEEP level has to be enough to prevent inspiratory collapse, but we have to be careful that our peak inspiratory pressure or plateau pressure is not high or too high to cause overdistension of the aerated regions. These two major mechanisms involved in ventilation-induced lung injury. So PEEP becomes a key issue in any recruitment ventilation strategy. But PEEP has to be seen in the context of recruitment. Only by applying PEEP, we can do more harm than benefit. And this is nicely shown in this patient that we studied. It was an ARDS patient with a severe ARDS in which we performed a PEEP trial. And we started performing the trial like I think most of you are used to do it in a clinical setting. We performed an incremental PEEP trial, incrementing PEEP levels from 5 to 20, first in 5 centimeters of water steps, then in 2 centimeters of water steps, up to 20. And we looked what happened to the oxygenation. Each level of PEEP was maintained for a few minutes. And you can see that even increasing PEEP to what we can consider high levels, nothing much was happening to oxygenation. There was no really a gain. So we ended at 20 centimeters of water, and we thought maybe if we challenge this lung a little bit more, come up to 25, maybe we have an additional effect. So we did that. And actually nothing happened. Even our oxygenation decreased. So it will be very difficult to establish which would be the ideal PEEP level, considering only oxygenation in this particular patient. But then we took PEEP and put it in the context of recruitment. We performed a recruit maneuver, which looked like this. We applied a recruitment pressure of 55 centimeters of water. This was a sick patient for 2 minutes with a PEEP level of 30 centimeters of water. After these 2 minutes, we reduced pressures again to the previous PEEP level, and our oxygenation just increased dramatically. And then we performed a decremental PEEP trial to try to find the best PEEP according, again, only to oxygenation. So we went down to 18. There we had some relief of overdistension. Our perfusion improved. Oxygenation went up. Then we went down to 16. Still a little increase in oxygenation. We reached the plateau at 14. And then by 12, our lung clearly collapsed, indicated by the fall in oxygenation. And then we came back to a level a little better than before. But on a decremental PEEP level, putting PEEP into context of recruitment, you probably would have set our PEEP level by 14 centimeters of water. So this is how we have been doing, or have been using oxygenation to titrate PEEP so far. But we are trying to study lung mechanics. And then let me just go back to a little explanation about the mechanical description of the lung during recruitment. This is a theoretical PV curve with its two components, the inspiratory or the inflation limb and the expiratory deflation limb. And down here I am showing the distribution of the opening pressures of the total amount of alveoli included in that lung. It's a theoretical distribution. So if we go through the different important parts of the pressure-volume relationship, we see that at the beginning, in this flat portion before the inflection point, we're not reaching any opening pressure, so we're not gaining any new alveoli. At this point, the inflection point is the point where recruitment starts because our pressure is high enough to start to open a certain number of alveoli, which are the more healthy alveoli, probably in the medium or upper parts of the lung. Through all the inspiratory limb, we have an important increase in the number of alveoli, and if we see the slope, which is equal to the compliance, we're reaching the point of maximum compliance. And then for a maximum recruitment maneuver, we have to force and drive our pressure up here to gain this final alveoli that are more diseased ones, probably in the dependent parts of the lung, who need this high pressure to be reopened or opened, but at the price of overdistending the lung, because here our compliance and the pressure-volume relationship is, again, coming to a flat portion. So we need to challenge the lung with higher pressure, have some minutes of overdistension to recover all these alveoli. And then we go to the deflation part. In the deflation part, we have a small decrease until a clear deflection point is seen in the deflation part. Again, here's the distribution of closing pressures of the alveoli of this lung. So at this point, we're reaching the pressure at which the most diseased alveoli become unstable and start to collapse. So collapse is an ongoing process through the reduction of pressures until we have a complete collapse of the lung, or the pressure is low that we even have airway collapse with airway trapping. Well, when talking about recruitment, there's always the first question is, how do we recruit the lung? What pressure do we need to apply to have an optimal or maximum recruitment? And this was shown by Hendershina. I will not go through all the protocol again, but this is a very nice study showing what we call the minimum opening pressures you need to apply, because I remind you that this study was performed in healthy individuals. They were studied with CT scans just after induction of anesthesia. And they made a stepwise inflation with 15 seconds of every pressure level with basal ventilation in between, and all the hours are indicating CT scans that were performed, seeing how the atelectasis were evolving with the different pressure applied. So the results in all the patients studied, if we in the y-axis the amount of atelectasis on the CT scan, we can see that for the different levels of pressures, only by 40 centimeters of water, the atelectasis actually disappeared from the CT scan. So we know for a recruit maneuver, at least the minimum pressure we have to apply in healthy subjects is 40 centimeters of water. Below that, you probably will have some areas of the lung that will still be atelectatic. Things are much different in sicker patients with acute lung injury, like this example. This is a patient with an acute lung injury. And you see that after 2 minutes of 40 centimeters of water, a recruit maneuver, there's still a lot of amount of collapse in the dependent parts of the lung, almost 10%. And obviously, we're not reaching the opening pressure of this very important part of the lung, important in overall lung function, with this pressure applied. So we challenged the lung a little bit more, increase up to 50 centimeters of water, and after 2 minutes, we could get rid, in this particular patient, having a minimum amount of collapse. So the pressures applied, it's dependent on a number of factors, but the main factor would probably be the degree of lung lesion, the degree of the lesion of the lung you have to treat. So clinically, and after a few years of experience, we have introduced in a protocol a pressure range between 40 and 60. It's a completely empirical result, but in our practice, whenever you need 60 centimeters of water of pressure to recruit, and you still have some collapse, it is very difficult to gain additional recruitment with higher pressures only in very selected cases. So with this range of pressure, you are recruiting most part of the patients. High pressures, probably only in very selected patients where there's where you have a lot of problems in ventilating without recruitment. So let's see how a clinical protocol works, still again using oxygenation as the reference. So the background is the oxygenation measured by a continuous online blood gas monitoring. And our clinical protocol goes for patients with acute lung injury. On the first phase, we determine the baseline ventilation. And these are the ventilation pressures, 28 to 10. Our PFA2 ratio at this point is 200. We performed a recruitment maneuver. In this case, we selected 50 of pressure and 20 of PEEP. We established this level of PEEP to stabilize the lung after recruitment. The response is an increase in oxygenation, and we take the criteria of a shunt reduction of less than 10% when looking at oxygenation. Then comes the most important part, which is finding the closing pressure. So we perform a decremental Peep Trial, trying to find the lowest pressure at which we can maintain this plateau in oxygenation. In this particular patient, we reduced first the inspiratory gradient, maintaining the recruitment PEEP level, and then in 2 centimeters of water step, we reduced the pressure until we reached 14 centimeters of water, where clearly all oxygenation started to decrease. So we took this value as the closing pressure of this particular lung after recruitment. The criteria for closing pressure was a fall in oxygenation of this plateau of more than 10%. Then we had to perform a new recruitment to regain this situation. Again, the opening pressures applied at the beginning. And our final ventilation with a pressure combination of 28 on inspiratory pressure, 16 of PEEP, a lower pressure gradient than the beginning, and with this PEEP level, we were able to maintain oxygenation on the same high level as achieved after the recruit maneuver. So this is how we have been doing this, and to learn about how to perform recruit maneuver. But you have to realize that online blood gas monitoring is not available probably to any one of us. So specifically when studying the upper lung tool, we wanted to look at mechanics. And this particular patient was studied also with the upper lung tool, where we could online, on a breath-to-breath basis, follow the evolution of dynamic compliance. And it looked like this. So we have a very similar behavior in dynamic compliance during the whole recruitment process. So this gave us the idea that there's probably a signal in lung mechanics studied by dynamic compliance, and they could probably go through the whole protocol of recruitment by just looking at dynamic compliance. And this is what we tried to study in this experimental protocol. So the data shown are airway pressures, the plateau peak pressure in orange, the PEEP level in yellow. Then we had online blood gas monitoring, and online, all these measurements were online on a breath-to-breath basis, and online changes in dynamic compliance. So the protocol consisted of just as you see in the recruitment maneuver, and then we focused on the most important part, the closing pressure titration. And here we had to have two precautions. First, make a small decrease, 2 centimeters of water decrease steps in PEEP, and maintain a low pressure gradient or low tidal volume to avoid tidal recruitment, which would interfere with our compliance signal. So I will refer on the data on the decremental Peep trial, and we will compare what we call so far the gold standard in oxygenation with the signal of lung mechanics, the compliance. So in this case, we found the closing pressure by about 14 centimeters of water, defined on one side on oxygenation. Here it started to fall, more than 10%. And it was coincident with, the maximum point of compliance. So this was our closing pressure. We performed a new recruitment maneuver and finally established the steady state ventilation with a PEEP level 2 centimeters above the closing pressure, in this case 16 centimeters of water. And so for the next period of time, we were able to maintain the gain in compliance that we see compared to the beginning and a plateau in oxygenation. So when now specifically looking at the behavior of lung compliance, lung dynamic compliance and oxygenation during a decremental Peep trial, in this graph, maintaining the same colors, white is compliance, blue is oxygenation. And this would be the typical response in a healthy atelectatic lung. We performed the recruit maneuver, and then we have a stabilizing PEEP level of 16, and we stepwise decrease the PEEP level, maintaining the pressure for 4 minutes on each step. And the typical behavior in compliance is a first increase, indicating the relief of overdistension, reaching a maximum value, after which our compliance starts to decline. At this point, the only explanation for this decline in compliance after a maximum value is lung collapse. There is no other possible explanation. And if we see the behavior in oxygenation, we also have a little increase, a plateau, and a decrease in oxygenation, almost matching in this healthy lung the point of maximum compliance. Another interesting information we got from having all this data online at the bedside was that even the behavior of compliance and oxygenation during the PEEP reduction trial could tell us about how good or how bad we performed during the recruitment maneuver. Because whenever we saw this behavior, that is, a continuous decrease in compliance and a continuous decrease in oxygenation, that only could mean one of these two options. Or either we didn't reach a sufficient opening pressure, so a portion of the lung remained collapsed, or the PEEP level selected at the beginning was insufficient to maintain this acute lung injury patient open after recruitment. So it's also telling you that information about the recruitment phase. So then we performed the study. We made two groups. One group of normal, healthy but atelectatic lungs, and there's a group of patients that we have included in this study, which are cardiac surgery patients. Cardiac surgery patients normally have normal lung functions, but due to the bypass circulation, they all have some degree of surfactant dysfunction, so they have a very atelectatic-prone lung. So it's a very nice clinical model to study lung collapse. This was one group, and another group was patients with sicker lungs, fulfilling criteria from the consensus conference of acute lung injury. So if you look at the first group, patients after cardiac surgery, and compared the behavior of compliance and oxygenation, the values are the mean values of 10 patients with the standard error of the mean, and these are the decremental PEEP values during the experimental trial. And we can see that compliance, we reached a maximum and a peak even before then oxygenation started to decrease. So in this group of patients, so far with this data, lung mechanics is an earlier indicator than oxygenation for indication of closing pressure and lung collapse. Oxygenation, the maximum was here, it started to fall by 10, and we had the shift. Probably in these healthy lungs, they have a good functional physiological system, and the interference of pulmonary hypoxic vasoconstriction probably may play a role in having a delay signal in oxygenation as compared to compliance. So things are much more different in acute lung injury patients. We're talking here about diseased lungs, very heterogeneous lesions. So lung mechanics is a more tricky parameter. Even though oxygenation was an early indicator, what we could detect in these patients is this maximum compliance point and the decrease. So at least we find a compromise, and we know that every PEEP level below this is way too much, way too low, because here we know that the lung is actively collapsing. So still an open question, and probably for further evaluations, is to establish this safety or the margin of safety establishing the PEEP level when looking only at the compliance. We so far, when using oxygenation, have been also empirically set the margin of safety of 2 centimeters of water. We thought that 2 centimeters would maintain a sufficient margin to maintain the lung stable. In this case, we probably, and this is a very stable difference between oxygenation and compliance, is between 4 and 6 centimeters of water, and maybe we have to expand our margin of safety when using only mechanics for titrating or PEEP level. So these were experimental data. I just wanted to show how this tool looks at the bedside. So this is the 3 screens we have available. The first one indicating pressures with the values here, peak pressure, plateau, and PEEP. The second graph is indicating the changes in volume. And the third graph is indicating the changes in compliance. So here we can see a complete recruitment procedure, which the pressure was increased to 55 centimeters of water. This is an experimental model. This was a pig. And with this tool, we can follow the behavior of pressures, the behavior of compliance, and identify important points of the whole sequence. And with the cursor function, we can go back after recruitment maneuver and see how we performed, how the lung performed during that recruitment maneuver, and compare it with further recruitment maneuvers in the evolution of the patient. So with the cursor function, we can go at the baseline ventilation, see what the parameters were, see when we increased PEEP levels, what happened to the volumes, what happened to compliance. Then during the recruitment phase, the pressures applied, the gain in volume, but the dramatic decrease in compliance. Remember that we are in the flatter part, upper part of the pressure-volume relationship. We are causing over-distension, and it's very nicely seen how the compliance decreases during the recruitment maneuver. Then we, after reducing this recruitment pressure, maintaining the gradient low, you can see that there's a dramatic relief of over-distension. We have a first plateau in compliance here. And then we proceed with the closing pressure titration. Here's the stepwise decrease in PEEP levels, our increase in compliance, a maximum, and here we have identified our closing pressure at 9 centimeters of water. So, to my knowledge, this is the first possibility that the clinician has at the bedside to detect lung collapse and titrate PEEP levels, so to optimize the recruitment procedure. Recruitment is submitting the lung to a very high stress with its pressures, and we should be sure that we find exactly the point at which we can maintain this lung stable in order to avoid excessive numbers of recruitment maneuvers due to lung instability. So it's important, the most important part is to find this PEEP value that maintains the lung stable after recruitment. So to summarize my presentation, what we found in the use of compliance for closing pressure titration is that you need to fulfill the prerequisites for an adequate interpretation. You need an optimal lung recruitment, and during the PEEP reduction trial, you need to apply low tidal volumes in order to avoid the disturbing effect of tidal recruitment to interpret lung mechanics. The information we get is we detect actually lung collapse after recruitment. We can recognize the adequate recruitment procedure by the behavior of this compliance after recruitment, and we are in the phase of describing different patterns of lung recruitment by looking by other data simultaneously, such as hemodynamics, see if a specific pattern for a specific group of patients is better than others in terms of tolerance and efficacy. And finally, we have, of course, a number of limitations. We only get global information of the lung. We know that ARDS is an extremely heterogeneous process, and probably with the pressures detected in a global fashion will cause overdistension in some areas of the lung. In the very severe patients, there's an underestimation of closing pressure because of the increase in lung heterogeneity. And we definitely need a new definition of a margin of safety when applying PEEP in this particular sick patients of ARDS when using only compliance to titrate PEEP. Thank you very much.
This talk is now open for discussion. Let me start before questions from the audience. Fernando, one of the things you talked about was, the amount of pressure you need to open up that last alveolus. And I'm sitting here wondering, everything is a trade-off. And do we know how much we really want to recruit the lung? I mean, it may be that in patients with ARDS that it's better to have 1% collapse, 2%, 3%, than use the high pressures required to keep that lung open. Can you just address that issue?
Well, I'm afraid I don't have a definite answer to that question. What we know is that the very high-end pressure is only to apply in the most sicker patients. And I think the maximum benefit of a recruitment strategy is when you apply this strategy early in the course of ventilation, when you don't have to use so high pressures. And normally with 45, 50 of pressure, you have excellent recruitment. You can get rid of all the atelectasis, and your PEEP level is not that high. What happens in the ARDS patients, some of them are not even recruitable at all. You apply pressure of 60, sometimes you dare to go to 65, and nothing really happens on compliance and on oxygenation. So it's maybe wise to not wait until your lung is sick, because I think the major benefit is this is a real protective lung ventilation strategy. So it's to go earlier in the evolution of these patients. But answering the specific question of what's better, have to have a little bit of collapse or a little bit of overdistension, because we're always moving in that range in these sick patients. I don't know. My guess is that I would rather ventilate a patient with a little bit of overdistension than collapse, because collapse can be an ongoing process. And if you don't have the adequate level of PEEP, and you still have some collapsed lung areas, any intervention, any little change that can cause some lung instability will cause your lung to collapse quickly.
From Istanbul, Turkey. I would like to ask, are there differences between primary and secondary ARDS forms in response to recruitment maneuvers?
Well, I myself, I'm not clearly convinced that primary and secondary ARDS are two completely different processes. What is true is that when a primary ARDS gets as sick as to produce a completely lung failure and in ARDS, you have a much worse condition than, say, in secondary ARDS, where you have an initiation of edematous lung and a global lung dysfunction. This is what I clinically normally have the feeling when trying to make a difference between primary and secondary is. I don't think there's a difference, and I think that every lung is recruitable, no matter if the cause lies primarily inside the lung or secondary outside the lung, say from an abdominal sepsis. The only thing is that the strategy and the rationale applies for both. Probably the way you obtain your goals is different. In primary ARDS, when you have a very, very sick lung, you probably will have to move in the very dangerous range of pressures, and this is not comfortable, and you probably will have to apply higher levels of PEEP. But I don't think that they are intrinsically different. I believe in different degrees of ARDS, but not really on the cause producing them.
Go ahead.
Yes, Tenonen from Finland. As you pointed out, it's quite difficult to set the limits, really. I mean, how high you can go. But I guess, like, my opinion is that one point of view is that you always have the other side, which is hemodynamics. I mean, you have heart-lung interaction, and you should always consider also blood flow, systemic blood flow, just for example. Another point of view is that you should ventilate, you should get rid of CO2 to a certain extent, right? Another point of view is the ventilation, to get rid of CO2 to some extent, okay?
Yes. Well, hemodynamics is always a consideration and is always a problem. But we have a little bit of luck we're lucky when applying recruitment strategies, because the sicker lungs, which needs the highest pressures, are the ones who are stiffer, and there's not a transmission to the pulmonary vasculature. So, in my experience, when you are in these high levels of pressure in these very sick lungs, your hemodynamics stays completely stable. When you are daring to recruit more or less sicker lungs, then you can have problems. But on the other hand, your pressures are much lower, with 40 or 45 centimeters of water, which can cause a huge hemodynamic problem if you're not aware of volume status and cardiac function. But I think you have to do this in a protocolized manner. Set a specific protocol. How do you want to have your patient? How stable? What's the volume status? What is the cardiac performance? And then, when you have all this information, try to decide what recruitment strategy you want to apply. So,
there's some more questions, but we'll have to do with a final question, please.
Barry Lyons from Ireland. Do you think you could recruit for using lower pressures if you change the patient position? Say if you turn them prone, maybe you could recruit without needing pressures of 65?
Yeah, I think there could potentially be a synergistic effect by turning the patient prone, especially not by the recruitment itself, but probably by the PEEP level you need to apply to stabilize the lung. So turn the patient prone changes the vertical pressure gradient, and it is I have never done it, but my guess is that you probably will have a much a relative more stable situation. The PEEP level would be a little bit lower than needed, but then you have to have the precaution whenever turning the patient back, the situation changes, and then you can lose everything because then your PEEP level is not enough. But I do think that there's a synergistic effect. Another question is that if it's completely necessary, if you can have a complete recruitment in a supine position, just to turn the patient prone, see if you can reduce pressure 2 centimeters of water or 3. So these are two different things. I think there's a synergistic effect, but I think that in a supine position you can achieve the goals if you have a rational strategy.
Thank you very much, Fernando.